Hello, everybody. I'm Dr. Petros Grivas. I'm a medical oncologist in Seattle. I'm a professor at the University of Washington and Hutch Cancer Center. And I'm very excited to see the amazing progress in the field for patients. And we see improved outcomes over the last several years in the field of bladder cancer. And bladder cancer is a very common cancer, has been cited as the fourth most common cancer in men. And if you put both men and women, it's about the sixth most common cancer. So it's very important to work hard to improve outcomes in this disease. And in that context, I was really excited back in 2024 in Barcelona at the ESMO annual meeting when I had the opportunity to discuss the data from the NIAGARA phase 3 trial that showed improved survival in patients with localized muscle-invasive bladder cancer. And just to give you a little bit more detail with that, this is a neoadjuvant and adjuvant, meaning a perioperative clinical trial that evaluated the addition of durvalumab, anti-PD-L1, given as neoadjuvant and adjuvant, as I mentioned, a sandwich approach, to the backbone of neoadjuvant gemcitabine cisplatin gemcis chemotherapy. So that trial took patients who were eligible for cisplatin, and it's not able to say that they used a cutoff creatinine clearance of 40 ml per minute or higher, which is this cutoff of 40 ml per minute is lower than the conventional cutoff for 60 ml per minute or higher that the conventional gastric criteria have used. So this is an important point to make there. So this population of patients, again, fit for cisplatin, were randomized to neoadjuvant gemcis, gemcitabine cisplatin, in the neoadjuvant phase up to 4 cycles with no planned adjuvant therapy phase in that control arm, or the experimental arm that added durvalumab to the neoadjuvant gemcis up to 4 cycles. Then patients in both arms had radical cystectomy, and in the experimental arm, durvalumab was given 8 monthly adjuvant doses if, of course, there was no reason to stop it because of toxicity. And that, again, perioperative approach of durvalumab was compared to the neoadjuvant only gemcis. The trial included more than 1,000 patients. It was a large trial designed back in 2018. So kudos to the investigators for getting this trial completed. And the results were reported initially at ESMO 2024. And we have seen several iterations of the results since then with multiple different updates that have been very useful to understand the data set in more detail and granularity. The primary endpoint of the study included event-free survival, and events were defined as progressive disease precluding radical cystectomy, recurrence after radical cystectomy, death from any cause, and also if the patients opted to not have radical cystectomy per patient choice, this was also counted as an event. So that's an interesting detail there. Overall survival was a secondary endpoint, and pathological complete response was another primary endpoint along with event-free survival. Overall, the baseline characteristics were very well balanced in the two arms, in the control neoadjuvant gemcis and the durvalumab arm, and approximately 15% of patients had histology subtype component. About half of them had squamous cell features. I think it's reasonable to also point out that if we look at the composition of patients, the vast majority had node negative disease. Only about 5% had a single perivesical lymph node N1. And if we look at the clinical stage, it's always, of course, hard to estimate the clinical stage, but it was, I would say, a meaningful proportion of patients had T2 and another T3 and T4. Overall, as I mentioned, it's hard to be very accurate in the clinical stage and estimation. However, I think the key points here is that if we look at the primary endpoint, event-free survival was significantly prolonged, and the hazard ratio for the event-free survival was 0.68, favoring durvalumab. So durvalumab addition to neoadjuvant gemcis with continuation of durvalumab adjuvantly significantly prolonged event-free survival, as I mentioned, hazard ratio 0.68 in the intent to treat population. And this benefit in event-free survival was in both subsets with and without pathologic complete response. So both patient subsets, those who achieved and those who did not achieve pathologic complete response, both those subsets appear to benefit from durvalumab in terms of the event-free survival endpoint. And if we look at disease-free survival in the subset of patients who underwent radical surgery, there was also significant benefit with addition of durvalumab. Perioperatively, the disease-free survival hazard ratio 0.69, again, favored durvalumab at perioperative addition. Again, disease-free survival pertains to the subset of patients who underwent radical surgery. And if we look at this population, if we look at the two arms, a similar proportion of patients in both arms underwent radical surgery. Actually, it was slightly higher proportion in the durvalumab arm. 88% of patients in the durvalumab arm versus 83% in the neoadjuvant gemcitabine arm underwent radical surgery. So it was reported that the neoadjuvant addition of durvalumab did not compromise the ability of patients to undergo curative intent therapy. So this was reassuring. And if we look at the data in more detail, the proportion of patients who underwent radical surgery, as I mentioned, similar, slightly higher numerical in the durvalumab arm. The time between the end of neoadjuvant therapy and radical cystectomy was similar in the two arms, about 6 weeks or so between the end of neoadjuvant treatment and radical cystectomy. Again, what do you expect with neoadjuvant chemotherapy alone? And the rate of surgical complications were very similar. So the addition of durvalumab neoadjuvantly to neoadjuvant gemcitabine did not impact the time to surgery or surgical complications, again, or the ability of patients to undergo radical cystectomy with curative intent. So these are reassuring data points. The other relevant point is overall survival. There was significant improvement in overall survival, hazard ratio 0.75, favoring the durvalumab arm compared to the neoadjuvant gemcitabine alone arm. And this, of course, overall survival benefit is very important as we know the impact that, when we have higher cure rates and longer survival for patients. If we look at the pathologic complete response in the intent to treat population, all comers, including those who did not undergo radical surgery, the pathologic complete response rate was about 37% in the durvalumab arm, 27%, about 10% difference in the neoadjuvant gemcitabine arm. But if you take the patients who underwent radical surgery, this proportion was 42% with gemcitabine durvalumab and about 33% with neoadjuvant gemcitabine, again, about a 9 to 10% difference there with higher path CR rate with durvalumab arm. As I mentioned, the toxicity profile was as expected. There was no new toxicity safety signal, and the quality of life patient report outcomes data appear to corroborate the clinical data, and we saw the patient report outcomes data in 2025 in a follow-up presentation. I think the totality of the data, efficacy, toxicity, quality of life overall support durvalumab addition to neoadjuvant gemcitabine with the adjuvant therapy phase of durvalumab, 8 monthly doses in those who can tolerate, as the new standard of care, the NIAGARA regimen in cisplatin-eligible patients with muscle-invasive bladder cancer. There was a lot of discussion about circulating tumor DNA. ctDNA is highly prognostic. We have seen that in multiple trials. Patients in this NIAGARA trial appear to benefit from durvalumab regardless of the ctDNA positivity at baseline. And if you look even at patients who had post-cystectomy ctDNA negative status, 9 out of 10, 91% of patients had negative ctDNA post-neoadjuvant treatment and post-cystectomy, and there appears to be a benefit with durvalumab in terms of the difference between the two arms in this subset of patients with post-ctDNA negative status. Again, adding some granularity. In my personal opinion, of course, there is risk of over-treatment and potential toxicity and cost, but there's also risk of under-treatment. And at the end of the day, based on the totality of the data, without knowing for sure if you need both neoadjuvant and adjuvant, my personal bias is to give both. Give both neoadjuvant and adjuvant durvalumab if someone can tolerate it, of course. It's usually easy in terms of tolerance and well tolerated in most patients. And I tend to give both neoadjuvant and adjuvant therapy phase as per trial design, again, with the caveats we discussed, of course. Talking about caveats, in the control arm, there was no planned adjuvant therapy because of the timing that NIAGARA was designed. and accrued was before the regulatory approval of adjuvant nivolumab in localized MIBC based on the pathologic stage and risk of recurrence. Again, this is a common theme when trials are designed before the landscape changes. Overall, I would say that NIAGARA is indeed practice changing. The difference in survival, event-free overall survival, is statistically significant and clinically meaningful. And again, this applies to the cisplatin-eligible population, GFR 40 ml per minute or higher. And of course, split dose cisplatin could be considered as an option in those with borderline creatinine clearance. Of course, the landscape is changing, and we're going to see data from Keynote B15 trial, EV304 at ASCO GU 2026 in this patient population of cisplatin-eligible patients. And we also saw already data from Keynote 905, EV303, in cisplatin-ineligible patients at ESMO 2025 from Dr. Volstecki. And of course, all these trials and of course other ongoing trials keep reshaping and keep informing the dialogue, how we treat patients with localized muscle-invasive bladder cancer. And of course, there are many ongoing questions going on. How do you treat patients who refuse, decline radical surgery? And how, of course, you may extrapolate or not this data to patients getting chemoradiation, bladder preservation. Of course, there are many questions about the challenge with checkpoint inhibition across other questions that hopefully we'll answer in ongoing clinical trials. I mentioned EV303, EV304, and of course there are ongoing trials like Volga and others that may keep reshaping the landscape. Exciting to see the progress made in the field and the better outcomes for our patients. And thank you so much for all you do and for your attention today.